Good evening. Welcome to today's webinar entitled Stereotactic Radiosurgery Acceptance Criteria for Arteriovenous Malformations and Cavernomas, an introduction to the measures of treatment options for patients with AVMs and Cavernomas. My name is Matthias Radatz. I'm the consultant neurosurgeon, medical director of Thornbury Gamma Knife Center, and senior clinician of the National Center of Stereotactic Radiosurgery in Sheffield. I'm delighted to be joined today by Dr. Stuart Coley, consultant neuroradiologist at the Royal Hallamshire Hospital in Sheffield, and by Mr. Neil Kitchen, consultant neurosurgeon at the National Hospital for Neurology and Neurosurgery and lead clinician for neuro-oncology.
Good evening.
Today's session is supported by Amethyst Radiotherapy UK. I'm very grateful for their support. Before we start, I'd like to quickly remind ourselves of the agenda. Introduction, that's myself. Treatment of brain dural fistulas by stereotactic radiosurgery, Dr. Stuart Coley. I will talk on radiosurgery for AVMs, current practice, do's and don'ts. And Mr. Neil Kitchen will talk on Cavernomas, indications for SIS and the CARE trial. Discussion and live Q&A thereafter. That's the agenda. And now the learning objectives, please. Current radiosurgery practices investigated, do's and don'ts for AVMs, treatment of brain dural fistulas by stereotactic radiosurgery, understanding the typical indications for radiosurgery in relation to Cavernomas, and Cavernomas, a randomized effectiveness care pilot trial planned in the UK. May I introduce now Dr. Stuart Coley with his talk on treatment of brain dural fistulas for stereotactic radiosurgery. Thank you, Stuart.
Thank you very much indeed, Matt, and good evening, everybody. It's my pleasure to be kicking off this evening's session. My topic for you is a rather niche area of radiosurgery, and that's going to be talking about the treatment of brain dural fistulas with gamma knife. Now, before we start talking about those fistulas that we like to select for treatment and how we go about it and its success, I think it'd be very helpful just to review some really important aspects in terms of the clinical presentation of fistulas and also their anatomical arrangement, because these are real key elements that help us decide who gets treated and also is very valuable in how we predict the natural history of our dural fistulas. Now, dural fistulas and brain AVMs are actually quite different. The image I'm showing you on the left is a dural fistula as opposed to the lesion on the right, which is a more typical brain cerebral AVM, which I guess many of you are much more used to. The dural fistulas are actually relatively uncommon, probably comprising about 10% or maybe less than all the brain dural vascular malformations. But they are a very interesting group of disorders and worthy of discussion in their own right. They're very different to brain AVMs. They present at a different age, typically in middle age and later life, and they present in a wide range of ways, whereas the brain cerebral AVMs tend to present at a younger age. Now, the key anatomical difference, of course, is, as the name suggests, the lesion in a dural fistula is not based in the brain or in the CSF spaces surrounding it, but it's actually in the lining of the dura itself. So typically, as you can see on the lesion on the left, I'll just come back to that image if I may. The lesion on the left shows a nice depiction of the vessels within the lining of the dura, sometimes within the falx, the tentorium, maybe the dural sinus. Just a reminder then, of course, the subsequent dural, venous drainage can actually be into the intracranial compartment, but the lesion is not in the brain itself. So where do we find most dural fistulas? The most common sites, as I'm sure you're aware, are in the transverse, sigmoid sinus, and cavernous sinus. And that accounts for probably up to about 2/3 to 3/4 of all the fistulas that's seen in most clinical practice. However, gamma knife is very different. Those lesions are now fairly readily treated in many situations by endovascular or possibly also with surgery as well. So the lesions we tend to see in gamma knife are different, and they tend to be located, for instance, the tentorium, the anterior cranial fossa around the skull base, areas that are difficult for a surgeon to get to, and also areas that are difficult sometimes for the pedicles for endovascular therapists to get to. Now, we know brain AVMs tend to present particularly younger, with hemorrhage, with seizure. Dural fistula actually present in a much more diverse sort of way. It may actually just be an incidental imaging finding that just crops up on a routine scan, or there may be some relatively mild symptoms, such as tinnitus and vertigo, that don't really bother the patient greatly. However, there's a complete spectrum of presentation, and it's really important to appreciate that, because some patients actually can present with hemorrhage, focal deficits, myelopathy, and dementia. So there's a real spectrum, and we can predict that partly by the pattern of the venous drainage from the anatomy. So that's what I'd like to move on and talk to you about next. Now, there's lots of classifications about dural fistula, and I have no intention of actually going into these, but really just to bring them to your attention. But the real key concept when we look at dural fistula is trying to differentiate benign lesions from aggressive. And by benign, I'm talking about dural fistulas that potentially can be left alone if you want to, because they have very little risk of neurological complication, stroke, hemorrhage, or death, as opposed to the aggressive ones that we can predict from the venous drainage that may actually present with fairly severe clinical complications. Now, this is a nice schematic drawing from an article which, if those of you are interested, I would advise you to read a little bit more about, that was published in AJNR in 2012. And this is a nice illustration of what we've described as a benign lesion. I'm afraid I haven't got a pointer to illustrate on the screen, but you can see there's the occipital artery, that's a dural vessel, coming up, and you can see a whole number of little fine vessels. That isn't the AVM nidus. A dural fistula does not have a nidus as such, but it has an arteriovenous shunt within the wall of the sinus. And you can see on that illustration that the arterialized blood going into the sinus drains out rapidly in an antegrade way. By that I mean there's no reflux backwards up the sinus, there's no reflux up into the cortical vein. And we know these lesions have got a low risk of subsequent neurological complication. And that's just a corresponding angiogram of a very similar lesion to the one I've just shown you on the schematic drawing. So antegrade venous drainage, no reflux, critical observations to make when we look at fistula. Now compare that with this lesion. It's the same pedicle, it's an artery, it's the same site in the sinus, and it's the same arteriovenous shunts. But the key difference here is there is obstruction of that sinus, there's a stenosis, it could be even a complete occlusion. And the consequence of that is you're now getting reflux back up the dural sinuses. And in this example, you'll also see there's reflux into the vein of Labbé. And that's really a key observation that you need to be making when we interpret all our angiograms. And finally, I've shown you cases that are centered around the dural sinuses, but also it's important to realize that if a fistula can actually directly connect to the cortical vein, and these are also patients that are high risk of neurological complication. So this is just an example of an aggressive lesion. This is a middle meningeal artery, a very small discrete fistula you can see in the wall of the sinus. It's not draining into that big sinus next to it. It's going into a whole number of small veins and then refluxing back into that sinus. That's an aggressive type. So refluxing into cortical veins. Okay, so I think you're getting the impression already that I'm slightly obsessed about cortical venous drainage. And the reason being there's a significant association in these patients with mortality, hemorrhage, and neurological deficit. And these are the ballpark figures, which you can actually see are greater than certain types of cerebral brain AVMs. Other predictors of aggressive behavior, as well as cortical vein drainage, are varicosities, stenoses in the veins, drainage into the vein of Galen, and you can also get a bad myelopathy, severe symptomatic myelopathy by refluxing to spinal veins. It's also some locations are associated with more neurological complications than hemorrhage, such as the anterior cranial fossa floor. And if somebody's already had hemorrhage, they are at an increased risk of having subsequent hemorrhage. So we take that very seriously. So a lot of these factors clinically and anatomically play into how we select patients who are best suited for stereotactic radiosurgery. So we like to treat patients that have these aggressive anatomical features that put them at higher risk. We also try and target patients that are symptomatic, particularly those that have had previous hemorrhage. It's often the case that we're finding that we're treating patients that haven't been able to be completely treated by endovascular or sometimes by surgical means. Now, ideally, the anatomy we want is to be relatively straightforward. And by that, I mean there's a relatively small number of small caliber arterial pedicles, a fairly obvious connection, arteriovenous shunting, and ideally a fairly low flow arteriovenous shunt into clearly defined veins. Now, of course, we rarely see that whole combination, but really, I'll show you some nice examples, hopefully, of where the sorts of lesions that are best suited. So this is a patient that came through our MDT relatively recently, who's a 55-year-old man that has an episode of increasing tinnitus. He undergoes MRI, and you can see this appearance in his posterior fossa. Now you can see straight away it's very abnormal. There are these enlarged veins, but it's very difficult to have any handle really on what's going on in terms of the nature of that vascular malformation. So patients typically then go on to have a catheter angiogram. This is a lateral catheter angiogram. And the slide on the left shows a very early phase, and you can see an injection into the external carotid artery, subsequently filling some rather tortuous veins. The image on the right is just showing a later phase. And looking at this image, we've done direct injection into these vessels, but it's still very difficult to understand what's actually going on this single projection. And so when we do DSA, we often need to do multiple projections, high frame rates, because there can often be quite rapid shunting. So this was probably the best projection, actually a fairly straightforward frontal picture that shows that enlarged pedicle coming up, the site of dural arteriovenous shunting in the dura, and you can see the subsequent filling of the vein on the left, a slightly later phase on the right. And just a bit of a tip for those of you that find this difficult to interpret, and this certainly can be very, very challenging, when you're trying to find out where the site of shunting is, because that's key to us, because that's the site we treat, one of the tips we use is to really just pick up that vein and work our way backwards. So find the vein and work your way backwards until you find the fistula. And that's certainly what we used to have to do before we started using things like this. So nowadays, we use CT and we use MR for localization, often all three, including DSA, CTA, and MR. And you can see this is a multiplanar CT angiogram showing very nicely that anatomical position of the dural fistula on the floor of the posterior fossa. On the midline, you can see those enlarged veins. We also use MR. We tend not to use the vascular sequences in MR. We tend to prefer the contrast sequence, and this is particularly helpful for showing the eloquent structures you may be close to. So here, it's quite safe to be treating this location, but you can see we are actually not that far away from the medulla, and so it is important to be accurate as possible. So when we treated this lesion, we used all three modalities. That's the angiogram that we used to show the fistula. And you can see the picture on the right, it's very difficult to understand where we're actually localizing to there. And that's the real advantage of using a DSA and cross-sectional imaging. We're able to co-register all of these on the gamma plan, and we can make sure we're targeting the correct part of the fistula. So this is just the four-year check angiogram, which shows you the frontal on the left, the lateral on the right, and you can see we've completely obliterated successfully that fistula. And this is just two comparable projections 4 years apart. The one on the right is the pre-contrast. You can see that fistula, you can see that big knot of tangle of veins is now completely gone. That little bit of reflux you can see in the top right on the left-hand picture is just flash filling of the carotid artery. Here's some more historical cases just to show that we were doing this back in the 80s and also in the 90s. And this is a very nice type of case to treat. This is a temporal fistula. And you can see here, this is very challenging potentially for a surgeon to get to certain parts of the tentorium. Very difficult pedicles to safely embolize down. But this is a patient that has a venous aneurysm and has reflux into the deep veins. This is a very good, suitable case to treat. And this is somebody that actually had a prior episode of hemorrhage. 4 years, sorry, that's just showing where we plan to. So we're targeting the dura where we believe the arteriovenous shunts are. we're not targeting the arteries, we're not targeting the veins, we're targeting where we believe the fistula is in the dura. And that's the angiogram 4 years later showing a nice result. And the last case I wanted to show you is something that you perhaps don't imagine that we do very often. And I think it's fair to say we treat these lesions less often than we used to, now that there's even more highly skilled interventionists who are able to embolize these. From time to time, they do come across, particularly if the interventional neuroradiologist can't get access, endovascular access into the cavernous sinus. So for instance, a case like this, there's no access via the inferior petrosal sinus. And this is potentially a nasty symptomatic lesion because you're getting reflex straightforward into the ophthalmic vein. You can get ocular hypertension, and these can be very unpleasant lesions to have. We've given gamma knife, and actually they can respond quite quickly. In fact, there's a nice series from Karolinska suggesting these actually respond certainly within 12 months of treatment, and you can see the nice clinical response. I don't really want to go into any case series in any great detail. As you can imagine, most case series are quite small. We first published our data on dural fistulas nearly 20 years ago, and I just really wanted to show you what we were treating, the types of lesions. So we studied 17 fistulas. About a third of them were at the tentorium, some were at the transverse and cavernous sinus, and then there was a bit of a whole sort of more esoteric locations, the petrous apex, falcine, lesions that are difficult for a surgeon, difficult for the lesions at those points for interventionists to get to. And even though we were using DSA, so this is a series basically of what was happening in the late 80s and 90s, we were, if you select your cases well, able to get angiographic obliteration up to about 80% of the time. And two other of the cases actually showed some arteriovenous shunting being reduced. Let's move on and quickly talk about the Karolinska. They published a larger number of fistulas a few years later. This is an important series because they were tackling some aggressive lesions, the Borden type 2 and 3s. These are these aggressive lesions I talked to you about. Half of these patients had actually presented with intracranial hemorrhage, and their series documented that you can reduce the risk of subsequent hemorrhage by radiosurgery. And they were treating very similar sort of distribution of cases that we reported around the falx, around the tentorium, superior petrosal sinus. And they were getting an obliteration rate approaching 70%, and noted up to about 90% of patients showed some level either of obliteration or reduction in flow. They did have some failures, and all these 5 failures in their series did occur when there was cortical vein drainage. And I think some of these patients then went back to the surgeon, and who was asked then to try and ligate the reflux into that cortical vein. And it was also described that these were lesions that were associated with high flow. Now, this is something we're often asked about. How would you say it's a high flow or a low flow? Well, there's no really good way of quantifying that. It's something that we can appreciate by observing the DSA. But fairly intuitively, as you can imagine, the higher the flow than the fistula, potentially the poorer the response to radiosurgery. So this is just the last slide I wanted to show you on terms of outcomes and complications. As I said to you before, it's very difficult looking in the literature to look at specific locations because these are fairly rare lesions, and it's fairly unusual to be treating them with gamma knife radiation. This is a nice conglomeration of a number of centres submitting their cases to a Gamma Knife Research Foundation, and there's a paper that was published in JNS in 2019. As you can imagine, this came from a number of centres. There was a variety of clinical practice. Most patients were getting somewhere between 20 to 25 gray, and they were achieving an obliteration rate approaching 70%. Bear in mind, of course, is a complete mixed bag of lesions. But some of the important things I thought to highlight for you, they were showing mean time to obliteration was around the 3 to 4 year mark, I should say, which is very similar to what we would expect to see with brain AVMs. They said they saw symptomatic complication in about 5%. Now, we're often asked to quote what we think the complication rate is associated with a potential treatment. And to be honest, I think you really need to do this on a case-by-case basis. Clearly, treating a lesion around the foramen magnum, maybe the condylar canal, is completely different to a much more straightforward convexity or falcine lesion in an area of the brain that's not so eloquent. But if you amalgamate all the data from that meta-analysis, they published a symptomatic rate and permanent deficit rate of fairly modest numbers. And perhaps the key aspect was they showed very nicely that you can reduce your annualized risk of hemorrhage back down to very low levels by gamma knife radiosurgery, less than 1%. Remember the slide I showed you before, showed in high-risk patients, that annualized risk of hemorrhage was probably somewhere between 5 to 10%, and that can be modified by gamma knife radiosurgery. So hopefully I've convinced you that dural fistulas are very interesting lesions. They have a wide range of symptoms and signs. I think they're particularly interesting to interventional neuroradiologists because if you make a good appraisal of the anatomy, it helps you identify those patients at the highest risk. We can predict natural history just by looking at the anatomy. I think it's important that everyone appreciates still that endovascular really is the first line treatment for dural fistulas, but I think gamma knife can really be a very helpful adjunct, particularly for those that is difficult to completely obliterate, and particularly at certain locations such as the tentorium, skull base, or falx. Thank you very much indeed.
Thanks so much, Stuart, for a fascinating talk on a topic that many of us don't have much experience in. So thank you for that. And a message to the audience: please submit your questions. We'll be discussing questions at the end of all three talks, but your questions are very welcome. So now it's my pleasure to introduce the next speaker, Matt Radatz, and who better than Matt to give a talk on the do's and don'ts of AVM radiosurgery. Thank you, Matt.
Thank you, Neil, for the introduction. So that's obviously a formidable task to talk about 35 years of experience of AVM radiosurgery in Sheffield in just 15 to 20 minutes. So I will focus on a subgroup of patients which is very rarely talked about and does have a very important role to play. And those are posterior fossa arteriovenous malformations and brainstem peritectal abnormalities. On this graph, you can see that the red columns, this is what we treat every year. They are making up about 44% of the natural incidence of AVMs in the UK. And we are treating about between 200 to 300 lesions every year. Posterior fossa AVMs, they are make up 7 to 15% of intracranial AVMs. They are associated with a high morbidity and a high mortality, typically in the range of about 50%. Rebleed rates are supposed to be higher than in supratentorial lesions, but I will show you later that that is in our experience not the case. The goal is total resection or complete obliteration. And due to the anatomical location, the eloquent placement of these lesions along the brainstem and the midbrain, these lesions are often not surgically accessible. Nevertheless, treatment options all have a role to play that includes embolization, microsurgical resection, radiosurgery, and clearly observation as well. MDT discussion is the cornerstone of treating AVMs. What makes a very important part in the management decision is the urgency treatment is required, the expected success rate, and the expected risk of such treatment. And with that conclusion, we come then to the primary formulation of the treatment pathway. Radiosurgical facts are that obliteration rate is dose dependent and complication rates are dose and volume dependent. And what is very clear, and that accounts for microsurgical resection as well, location is materially important and matters most. That's very nicely shown in a publication by Flickinger in 2000, where he evaluated the toxicity of the 12 gray isodose volume for different parts of the brain. You can see on the left graph, the top line is the pons and midbrain line. It shows that this is a part of the brain most susceptible to injury by radiation. So the higher the volume of a 12 gray, the higher the risk that you get a side effect. And on the right graph, you can see the second line from the top. That is a medulla. And this shows that the medulla is actually much more radiation resistant than the pons and the midbrain. We take that as knowledge forward. Now, we have learned a lot from our large series, in particular the large series published on lesions over 10 cubic centimeters. That's a formidable group. And what we have learned in this group is that the hemorrhage rate when you have never bled is actually much more reduced and smaller in the hemispheric group than in the deep eloquently placed group, about 10-fold smaller. And the same accounts for lesions which have bled, because the hemispheric lesions have a much lower risk of rebleeding once they have bled than the deep eloquent lesions, which go up to a rehemorrhage risk of nearly 17%. Now, when we look at our outcome of those lesions, then I concentrate on the middle, the right-hand bar, MRI total. That is a modern series of our radiosurgical experience for large AVMs, which is based on AVM dose planning on the grounds of DSA and MRI and very sophisticated dose planning itself on the gamma plan. In this group, we can show that we can obliterate lesions over 10 cc in about 60%. Now, what we could show in that group as well is that our success rate is dependent on if a lesion has been pre-embolized or not. And pre-embolization has a very negative effect on obliteration rate. So in an ideal world, what we want is a lesion to come to radiosurgery before it is embolized. What we have learned in that group as well, leading to our staged approach, is that the risks of side effects increases in lesions with over 10 cc volume, and is in the range of about 16%. So by reducing the exposure and reducing volume by staging this in this formidable group with, you can see a large cohort of Spetzler-Martin grade 3s, 4s, and 5s being treated in this way, we managed to bring down the side effects from 15.6% down to 6.5%, just by the fact that we treated the AVM in 2 or 3 portions. That has not affected the obliteration rate, which remains at about 60%. So in summary from that group, we would say, we don't like pre-embolized AVMs to treat with radiosurgery. We would like to treat them before they get embolized. Any residuum needs to be discussed again in an MDT, and all options need to be re-explored. Very rarely in these lesions, we have significant mortality or morbidity. Now we are looking at our deep critical lesions, and I want to concentrate, as I said before, on the posterior fossa ones. We have looked at 160 brainstem lesions, and we have additionally looked at about 53 peritectal lesions. Now, when you look at the graph in the right bottom corner, that is how many of those lesions present actually with hemorrhage. And it is quite evident that the vast majority of those present with hemorrhage. So there is indeed a significant risk factor having a lesion in the posterior fossa. So midbrain, nearly 95% of these lesions present with hemorrhage. Very few are incidental findings, and the bleed is typically associated with a material risk of a neurological impairment. Now we move on, looking at where they were located. When we are looking at the midbrain and the pons, you have the cisternal space, about 30 to 40% in the cisternal space, partially parenchymal, Parenchyma does matter because it is highly eloquent, makes it less accessible for microsurgical resection, about 30 to 40%. And then you have the deep parenchymal lesions, which will probably be graded as non-operable in about 30%. The volume of those lesions varies greatly. The majority of them are small, but there are some formidable lesions in both groups. And on the bottom, previous surgery and embolization, you can see hardly any of them have been attempted to be treated by other modalities. And typically they're either down to observation or to radiosurgical management. This is just a subgroup picture of a midbrain tectal arteriovenous malformation treated. You can see superimposed the dose plan on the digital subduction angiography on the top in the MRI axial imaging. The yellow line is a prescription isodose line. That means the AVM is within that line. And that receives typically, depending on the location and the eloquence and the volume, 20 gray to the 50% isodose line. That means that the peak dose is about 40 gray, which is a formidable dose. The next slide here shows a subgroup of the pontine and medulla lesion. And again, the isodose line superexposed on these images. On the top, the DSA and the MRI scan below. The inner green line is a 20% isodose line. So even within that line, you already don't have damaging irradiation, which you are worried about causing you a neurological impairment. So these are very tight dose plans, and one needs to be very careful to extrapolate our results to other machine hardware where such steep dose fall-off may not be achievable. Important in that group and verifying the data we have published on these posterior fossa AVMs is the fact that when we looked at the pre-treatment hemorrhage of these lesions, you can see that the first ever before treatment risk of having a hemorrhage is actually equivalent to the Aruba trial, stating 2.3% for lesions which have never bled. And this, it's uncanny, but it is basically what we could show in that study. What we could show as well is that, yes, there is an enhanced hemorrhage risk if once they have bled again, but it is not as high as in the supratentorial group. Even in the higher group, the midbrain group with 11%, it doesn't come to 16%. So it typically in the range around 6% in the posterior fossa. And most importantly, once they have been treated, the risk goes down to the pre-treatment risk, around 2 to 3%. And that is very much against what is often said and argued about stereotactic radiosurgery, that the effect is only visible once the lesion is completely gone. There is an ongoing effect from the day you have started treating that patient. Whilst protection is not there immediately, there is clearly a protective effect here. Now, preterm morbidity undoubtedly in these eloquent lesions, with the majority of them presenting with hemorrhage, is pretty bad. And you can see that in the midbrain, 50% of patients come with a neurological deficit. The peritectal group is a better group presenting, but the pontine group with 60% of neurological deficit is again not to be underestimated and in a way expected. When we are looking now at the obliteration rate, then the pontine and medulla group is a better group. They respond in 65 to 70%. There is a volume dependence, and over 4 cubic centimeters, the results are not very good. In the midbrain group, the first treatment only in about 50% is successful to obliterate. And the majority of these lesions need a second treatment about 3.5 to 4 years down the line. The beauty of the midbrain there is that these lesions, and in particular the peritectal lesions, tolerate a second treatment very well without additional side effects. And the obliteration rates reach 80 to 90% with the second treatment. When we are looking now again at the outcome, we want to focus on the two bars on the left in the A graph and the B and the C graph, because what we want is an excellent and a good result. And what we are not too worried about is an unchanged result, because at least we haven't done any harm, even though we have not cured. What these graphs clearly show, that you do not want to treat lesions in these eloquent parts of the brain in a single session above 4 cubic centimeters, because your side effects become really intolerable and you have patients who have poor or very disabled outcomes. So aim is complete elimination of an AVM with lower morbidity. Size and location are major determinants of radiosurgical outcome. Radiosurgery is safe and effective in AVMs smaller than 4 cc. Obliteration rate is low in the midbrain, but side effects are mild and low, and repeat radiosurgery is very successful. In the medulla and pons, typically 65 to 70% cure rate, whilst in the midbrain with the first treatment under 50, with the second treatment up to 90%. Brainstem lesions over 4 cc should not be treated. High complication rates and poor outcome. Post-treatment hemorrhage rates were lower than the rebleed rate in this group. Now, a few examples. Presenting with trigeminal neuralgia, a patient with a large, formidable posterior fossa AVM, transient diplopia after treatment, facial pain gone, and off medication, angioproven cure 3.5 years later. You can see that stereotactic planning scan above, the digital substructure angiography, and the cure below 3 years later. Another example, a staged treatment for trigeminal neuralgia. This was not hemorrhagic presentation, pain-free after 12 months, staged in 2 portions around 11 cc. We treated in the first instance the lower portion of this abnormality, and then in a second treatment, you can see on the first stage angiogram, and in the second treatment, the superior portion of that AVM. And again, that achieved a cure. 2 small remnants. In the anterior and in the posterior components of a large AVM treated. These were outside the dose planning of the original treatment. And so this patient had a stage treatment, 2 stages, and then 4 years later, we picked up the remnants. And because this was outside the previous dose planning, this part of the brainstem in the right picture, the axial image, did not have any previous significant radiation exposure, so it could be delivered very safely. Another example, acute hemorrhage with 3 embolizations to treat fistulae, and then that was followed with stereotactic radiosurgery, leading to complete obliteration 3 years later. Now, there are always lesions where you think, well, am I a cat or am I going to be a lion? Can I take this on or not? And there are lesions clearly which you cannot take on. And no doubt we chickened out on that one, and we settled for treating the trigeminal nerve to address the trigeminal neuralgia successfully, which was pain-free this patient within 12 months. Now, DOS in posterior fossa radiosurgery, multidisciplinary approach, most important. Radiosurgery is an elective treatment option, but should be considered prospectively even in the acute phase. Size and location are major determinants of radiosurgical outcome. Radiosurgery is safe and effective, even in non-microsurgical deep and eloquently placed AVM smaller than 4 cc in brainstem and midbrain. Cerebellar lesions over 10 cc need staging. Obliteration rates are high in the pons and the medulla with a primary treatment, and in the midbrain with a second treatment up to 80 to 90%. Clear don'ts, stereotactic radiosurgery has no role to play in the acute hemorrhage phase. Brainstem lesions over 4 cc are poor outcome and poor obliteration rates, and they should not be treated in a single session. Patchy embolization is not useful, and embolization itself reduces the overall obliteration rate. Most importantly, incurable lesions should not be treated in the first instance and should be observed. And last slide is the volume stage radiosurgery will have an increasing role to play in posterior fossa AVMs. Thank you very much to the team, and thank you very much for giving me the opportunity to talk today. Now, I'm going on to introduce Neil Kitchen to give his talk on cavernomas. Neil, please go ahead.
Thanks, Matt. So the first vascular pathology we're going to discuss tonight is cavernomas, which, unlike the first two, is not treated with embolization at all. So we just have to consider surgery and radiosurgery. And in particular, I'm going to be talking about the CARE study, Cavernomas, a randomized effectus, a pilot trial of which I am the co-investigator. Brain cavernomas are quite common conditions. There's over 114,000 people known to have cavernomas in the UK and Ireland. Brain cavernoma incidence is about just under 400 per year, and this has increased since the studies in Olmsted County in the 60s, 70s and 80s to Scotland in the around the turn of the millennium when MRI scanning was more prevalent. So if one looks at incidental brain cavernomas which have symptoms, there's about 160 per year in the UK and Ireland. And these are a number of population studies from various countries in the world published in Lancet Neurology in 2016. And essentially the two symptoms which cavernomas cause are seizures and intracerebral hemorrhage. So this is probably the most important slide of the whole talk. This again is from the Lancet Neurology 2016 meta-analysis study, looking at the 5-year bleed risk of cerebral cavernomas. And if one looks at location and whether the patient has already had an intracerebral hemorrhage or focal neurological deficit or not, the hemorrhage risk ranges from 30.8% in a cavernoma in the brainstem which has already bled, down to 3.8% in an incidental cavernoma not in the brainstem. So this is less than, so the last example is less than 1% per year, whereas the first example is up to 6% per year. The other important symptom cavernomas can cause are seizures, and again this is from the neurology study in 2011 looking at AVMs and cavernomas. So forget the red line. The black line are cavernomas which show a very poor prognosis if they present with seizures in terms of continuing to develop a seizure disorder. So what are the treatment options? Well, there's conservative. That's the scan and wait and monitor with MRI scans. The problem is how often and what sequences of MRI to use. Or microneurosurgery excision, or gamma knife stereotactic radiosurgery. This is an example for surgery of a large cavernoma in the brainstem, a 47-year-old patient presenting with 2 months history of diplopia and paresthesia, and then a sudden deterioration in gait and right hemiparesis. This cavernoma was excised via fourth ventricular approach, and one fact of follow-up of cavernomas treated with surgery is that you can see whether you've removed the cavernoma or not, such as in this case. If you look at the various studies to do with neurosurgery for brain cavernomas, this is a meta-analysis from World Neurosurgery and Neurology combined together in 2013 and 14. This top group are largely supratentorial series, whereas the bottom group are brainstem and deep thalamic series. You can see that early postoperative morbidity, particularly in the brainstem, was very high. Complete excision was not achieved in all cases, but in 91%. But if you only partially treated a cavernoma, the rebleed rate was pretty high. So surgery, these studies show that surgery is not without risk. And if you look at purely, these are papers, essentially case series describing deep brain cavernoma neurosurgery, the risk of death or disability was 9%. There are comparative studies of neurosurgery versus medical management, which I'm not, and these are the important examples shown here, which I won't go into, but just to show that the relative risk of active versus conservative management varies, as you can see, from less than 1 to 7.8%. So the findings are not uniform. Now, when we come to gamma knife, the principles are similar to previous speakers. Most importantly, good patient selection. If the cavernoma has previously bled, waiting for at least 3 months after the last hemorrhage is generally felt to be better at target delineation and also for brain recovery. And the smaller the volume, the better the treatment. In terms of planning, prescription doses, as with most stereotactic radiosurgery, have decreased over time. And importantly, one wants to keep the treatment volume within the hemosiderin ring. And one must avoid developmental venous anomalies, which, as you know, are often associated. So here are some examples, again showing the treatment volume and isodoses. And note the difference between these and the surgical cases. Generally speaking, cavernomas treated with SRS are much smaller than those treated with surgery, generally speaking. Here's another example of a cavernoma within the medulla. Again, you can see that the treatment is maintains within the hemosiderin ring. In terms of long-term follow-up, there are no definitive MRI criteria of cure as opposed to AVMs. And as you can see here, a cavernoma 4 years later may look pretty similar post-treatment. Here's some other further examples. Again, very small treatment volume. And again, the cavernomas often look exactly the same or pretty similar many years later. And so the key to follow-up of SRS to cavernomas is not really radiological, but clinical. So what studies have been done with SRS in cavernomas? Well, again, we turn to the National Centre in Sheffield for their large series. And this was a paper they published in 2018, which is what I call a before and after study, looking at over 200 deep-seated cavernomas, which was stratified into 2 groups by risk. There were those who presented and were treated when they'd had a single hemorrhage, and those which had previous multiple hemorrhages. In the single hemorrhage group, the estimated annual bleed rate prior to treatment was 2.4%. The 2 years after treatment, this did increase before subsequently decreasing again. And this effect was more dramatic in the cavernomas which were chosen for treatment who had multiple bleeds. And again, this is seen graphically. This would be the pre-treatment graph, or this is the post-treatment graph. These before and after studies are relatively common in SRS, and here are some other smaller studies which predated the Sheffield study, which showed in the main that the relative risk decreased after SRS as to compared to before treatment. Having said that, we know that rebleeds do tend to cluster in the first year or so following initial bleeds of cavernomas. So this may be a clustering effect. And in these papers, the patients themselves are their own controls. So are there actually any comparative studies of SRS and medical management? Well, there is one, which is a small study of 41 patients, and they found that though the ICH and adverse reactions were higher in the actively treatment group, relative risk was incalculable because of the small number of patients. So what do we do? So we looked at what were the most important priorities for research into cavernomas. This was over 5 years ago now, and out of the top 10, the biggest, most important factor was, does treatment with neurosurgery or SRS or no treatment improve the outcome of patients diagnosed with brain cavernomas? And so this CARE study has come about, and this is a collaboration of all relevant specialties in neuroscience communities in the UK and Ireland. And we're currently embarking on a pilot study, a feasibility study of 60 patients. So what is the format of the study? The patients are screened, and then eligible ones are approached, consented, and randomized. This is the standard RCT formula. If there is a preference for type of surgical management, for example, a large subcortical cavernoma, if the preference is surgery, then that patient will be randomized to either surgery or medical management. If the preference is, if there was going to be an active treatment for a stereotactic radiosurgery, then that patient will be randomized either to radiosurgery or medical management. And so in effect, there will be 2 arms to this study. Importantly, there will be central as well as local clinical and MRI follow-up, and the outcome will be, the radiological outcome will be adverse events and MRI follow-up at 6 months, and then followed every 6 months thereafter. So where are we at? We needed to show that we can do this pilot study so that the definitive main phase trial can be done. And we this month starting to activate sites in the UK, in fact, every single neuroscience centre. And we hopefully by the summertime will begin screening and recruitment to end recruitment of those relatively small number of patients by the end of next year, with follow-up 6 months later, and then reporting and dissemination. With the aim to form a definitive international main phase randomized controlled trial to answer the question, is radiosurgery or surgery better treatment than the natural history of cavernomas? Thanks very much for your attention.
Thank you, Neil, for that very interesting talk, and with the very interesting prospect of a randomized trial for cavernomas, which is an amazing achievement. Now we have some interesting questions, and what I will read them out, and then we'll see who from the faculty is best placed to answer the questions. So the first question is for Dr. Coley. Were there any instances of hemorrhage of aggressive DAVFs in the time frame between SRS and obliteration?
In a particular series?
I think it assumes in our series.
I mean, our series that we published was actually a very low number, so we didn't actually have any rebleeding events. But very much the philosophy is like brain AVMs, although Matt did indicate earlier that there is some modification of bleeding risk in the treatment of brain AVMs as the radiosurgery is taking effect. Very much our philosophy is to make sure we completely reduce and then obliterate that shunt. So there is the data on dural fistulas is a much smaller than brain AVMs, I'm afraid. So it's difficult to really say that that's true. But as I said, our philosophy is very much to obliterate the shunt completely. And yes, there have been episodes of rebleeding when in cases that have not been completely treated, and that was actually shown quite nicely, I think, in the Karolinska data.
Thank you, Stuart. There's a question for probably best placed for Neil. there's no proof of cure of stereotactic radiosurgery for CVM. What follow-up would you advise for such treatments after radiosurgery?
Well, that's the thing. So, as I said, I think the principal follow-up is clinical. The proof of the pudding is if a patient presents with several hemorrhages prior to gamma knife therapy and then has no hemorrhages for a period of time thereafter, that's a that's a good thing. Unfortunately, what's happened is that in many series, patients have been treated perhaps following one hemorrhage or not even any hemorrhage. So it's very difficult to know what the positive or otherwise effect of the radiosurgery has been. So I think the most important thing is clinical follow-up, and scanning the patient really is important if they have some clinical event, but perhaps not routinely useful post gamma knife.
Thank you, Neil. Now there is a question, could these SRS treatments be carried out on a standard LINAC? So I think I'll take this, we need to answer this in two portions. AVMs versus Cavernomas. The AVMs I was talking about, I think I would be very cautious to treat them on a LINAC accelerator, and I would be very cautious to extrapolate our results to a LINAC accelerator for two reasons. The prescription dose on a LINAC accelerator is typically different. It's to a higher isodose line. That means that the penumbra receives more irradiation, and the 12 gray volume will be increased because you still need to give the prescription isodose 17.5 gray to be successful on an AVM obliteration. And there are some new LINACs now which will get, and the CyberKnife certainly gets very close to a very similar dose plan than the gamma knife, but that often requires many beams, which for purposes of suitability and time are not delivered. And so the dose plans are often accepted at an inferior level. For Cavernomas, Neil, what do you think? LINAC accelerator?
I think the size and position of the lesion precludes that, essentially. Plus, all the experience worldwide has been with gamma knife, so I wouldn't be comfortable using a LINAC for Cavernomas. Okay.
Another question for Stuart Coley. Does choice of embolic material influence efficacy? AVM SRS post-embolization. E.g., do tantalum-based embolics do worse than iodine-based embolic agents?
I think in terms of eradication and obliteration of dural fistulas, I think that's completely unknown. I think, as you mentioned in your talk, that in fact there's lots of things we don't know about brain AVMs, but one of the things we do know is that embolization typically makes it more challenging for obliteration. We don't have anything like that amount of data for dural fistulas. All I would say is if someone is considering taking on a dural fistula for embolization, which I really do believe is the primary first-line treatment, then the key thing to say is that embolization should be taken on with a view to completely eradicating it. So we don't ideally want to take an embolized dural fistula and to tidy up what's left. Obviously, sometimes things are unpredictable and it's not always possible to get every single part of it. And remember, of course, a partially treated by radiosurgery or even a partially treated lesion with embolization can actually make it more dangerous. So embolization, I think, does make it more challenging for targeting with dural fistula as well. In terms of the pathophysiology, does it make it harder to obliterate? That evidence is lacking. And as to whether any of the different endovascular agents and embolic agents make a difference, I have no idea, I'm afraid.
Okay, there's another question. What volume of AVM in the posterior fossa would you volume stage? I can answer that. We would volume stage volumes above 10 cubic centimeters in the posterior fossa if it is in the cerebellar hemispheres. If it is in the brainstem, then clearly you need to reduce that volume materially. You would probably want to start staging already at 4 cc. Yeah, so it depends on location and eloquence to answer that question. Another question here, is a risk of second line embolization or maybe post-SRS surgery after previous unsuccessful SRS increased, and if so, how much? Stuart, do you want?
Again, the data doesn't exist. We don't really know. I think generally most people would say when you're going on to a second treatment, a third treatment, whatever it is often more challenging. We have certainly seen the cases, and they've been described in the literature, when someone's not always been able to completely obliterate a fistula. There was a residual reflux in cortical vein, which is the malformation has been made a bit smaller, and then a surgeon has been able to go in and specifically ligate that. But it can be difficult, not least in trying to localize it. But no, I think the actual data on that, we don't have that.
Okay. Another question. The MDT suggests that the fistula will require both endovascular and radiosurgical treatment. What would you address first?
Well, I think we've slightly touched on this already. I think when you're primarily trying to treat these lesions, we're not normally thinking this is going to be a staged treatment with 2 modalities. I think clearly an end of the more modern agents and the more experience with interventional neuroradiology now is, as I said, I think it is much easier and much more possible to effect a complete obliteration of that fistula. And that should be the primary aim of dural fistula management with embolic agents. So the way it tends to work out is we sometimes are asked to pick up some small remnants. That is when for instance, the glue hasn't, the embolic agent, I should say, hasn't fully penetrated the fistula, has not fully closed the vein. And then we are therefore sometimes left with either surgical ligation or radiosurgery. But I think we would always prefer somebody, if embolization is thought to be suitable, it should be potentially curatively, it should be taken on, the attempt to cure.
Thank you, Stuart. There are 2 questions. Why does the panel think that previous embolization has a negative impact on SRS results in AVMs? I think I will answer that. It's not totally clear. It depends on what agent. There have been reports that onyx is associated with neovascularization. That may be one of the reasons. The other one might be that the radiation delivery, the ionizing radiation delivery is not as anticipated on the dose plan because of the density of the embolizing material affecting that dose plan. So that in fact we under-deliver radiation into the nidus, and that would be very plausible why pre-embolization has a negative effect. But there are certainly, it's not a cast iron knowledge there, and there is still some lot of knowledge to be acquired here. Another question for a simple dural AVM from the occipital artery, why not tie the artery? Will it reform? I think if you have a simple dural AV fistula and you just tie off that fistulous vessel, it should not reform. You should have cured it. And if that is easily accessible, I think that would be probably the treatment of choice.
I'd slightly just disagree with you there, actually, Matt. I mean, a bit like AVM treatment, it's very important to hit the arteriovenous shunt. So one of the things we don't do is treat the micropedicles in the same way we don't embolize these feeding arteries. unless you ligate the site or obliterate the site of arteriovenous shunting, be it within the cortical vein, be it within the wall of the dural sinus, which where most of these fistulas are.
Okay.
So actually, just purely tying off or proximal ligation of a dural fistula will have some short-term benefit, and actually it may actually lead to some thrombosis within the sinus. But in terms of the pathophysiology, that's not what we're really trying to achieve. We're trying to obliterate shunt in the same way as we're trying to obliterate the nidal shunts in an AVM.
Okay, I took that question like that you remove that fistulous component completely, and that once that fistula is taken out, that you would not expect it to reform, would you?
Well, the problem is it depends. Unless you get your embolic material or your radiosurgery thrombobliterative effect in that site of the arteriovenous shunting, you're then leaving a potential for revascularization in the wall. One of the thoughts about dural fistula is that there is an abnormal angiogenetic response in the vessel wall, potentially with infection, potentially with thrombosis. And if you're essentially then only proximally taking out some of the vessels, you can still allow the encouragement of these other channels to open up. And so a bit like an AVM, you'll just get recruitment from other areas potentially. So you need to hit the site of the shunting, not just the proximal feeders.
Okay, thank you very much. I think that is all what we have time for today. We hope that you found this session both informative and engaging and interesting. I'd again like to thank Amethyst for supporting this event. I'd like to thank the faculty, Mr. Neil Kitchen and Dr. Stuart Coley, for their fantastic talks. And I'd like to say thank you for the interest in this webinar, which has been very significant, and we are very pleased with the number of attendees. On this, I would like to say, have a lovely evening, and thank you very much. There will be more webinars to come in the future with part 1, 2s, and 3s from the AVM point of view. And I'm sure that once we are down on the trial for CVMs, that there will be more to report as well. Thank you very much and have a good evening.
Good evening.
Good evening.